Okay, so when Laura contacted me, she gave me a topic, and I was just like, well, this is great, but it's also a challenge because, to talk about heterotopic ossification, there are some things that we know about, but there's actually probably more things that we don't know about heterotopic ossification. And so what we thought we would do for this, first session was really to talk a bit about the challenges managing heterotopic ossification and some of the approaches that we have used here in our clinic over at UCSF to sort of thinking about what can we do and how can we help the patient. Um, as many of you know, and to be quite honest with you, there really is no clear consensus on most of this, and so this is what I would consider very much an art form, in terms of medical management. And so I think that there will hopefully be a lot of discussion from different people if you're willing to share about some of your experiences and some of the different types of directions. But this I think is actually an area of a lot of learning to come. So just very quickly, I do have some disclosures. I do clinical trials in patients with FOP and their heterotopic ossification. We do receive clinical trial funding through the institution for that. And none of this poses any conflicts for what we're talking about today. Okay, so when we think about heterotopic ossification, I like to think about this, from the standpoint of normal bone development and the balance of breakdown and repair really for homeostasis. And to everybody here, I think it's pretty clear, that there are some forms of bone-forming cells, whether they're osteoblasts or other types of cells that might be present in a particular tissue. And then there are cells that are going to be osteoclasts, and that these are the ones that break down bone. And the to me, one of the critical things to think about is that there are a lot of different types of modifiers. There are different factors that actually go into regulating the normal skeleton and the normal bone development process. These may range from genetics and hormones to the immune system and electrolytes, different metabolic factors. And there's growing interest now in terms of like the central nervous system and the peripheral nervous system as key regulators of the bone formation cycle. For our purposes today, in terms of like thinking about heterotopic ossification, we're not going to be talking so much about native bone and bone development, but this type of system and this type of approach and of the different types of cells are also present in the locations where we get heterotopic bone. And so it is useful to keep these types of mechanisms in mind. One of the things that has always been very intriguing to me, and I think to many others, is that there are many shared pathways, but clearly there are unique initiators and different types of, and you end up with different results based on these initiation factors. So even though we have cells, transcription factors, and other genes, and that these are the shared bone formation mechanisms, depending on your location, different types of genetic factors, whether there's tissue injury, sort of what we call initiating factors, those all impinge on these common mechanisms that eventually form the different types of bone morphology and just species differences in bone structure. But they also contribute to diseases of abnormal bone formation, whether these are orthotopic, meaning that the bone is forming in the right location, but just perhaps the wrong shape or the wrong type of structure, or heterotopic, where you actually have abnormal bone formation occurring in a tissue that is not normally mineralized. And the nice thing is that there's been a revolution in a wide variety of tools over the past 10 years. And thinking about rare diseases has really allowed us to inform these common mechanisms, specifically because there is this shared portion in the middle that allows us to think about the shared bone formation cells and pathways. So when we think about heterotopic ossification, we're talking about bone that forms in an abnormal position. And the two normally mineralized tissues are the teeth and the bones. I will say, as I was going through looking for different images for the slides, I was sort of playing around with Gemini, which is this the Google version of AI that can actually do image processing. And as some of you may know, that AI generated images have a lot of trouble with teeth and with hands, and so you can actually see that here in this particular skeleton. So I just thought that was kind of interesting to note. But when we think about the mineralized tissues, and we're looking at abnormally mineralized tissues, it's really important for us to think about how the different types of mineral deposition that occurs. And so one aspect that we see in a lot of different diseases, particularly inflammatory diseases, is this concept of calcification and calcinosis. And in this situation, this is a deposition of calcium or calcium phosphate complexes. It can pretty much occur in any tissue. And a key characteristic behind it is that it's a relatively disordered process. You have these calcium deposits that actually occur. They're driven by inflammatory processes. So this is actually seen a lot in rheumatic disorders, dermatomyositis, scleroderma. COVID has this too. And also in trauma and for patients who take care of for clinicians who take care of patients with renal disease, especially in end-stage renal failure and with dramatic mineral disorders, you can see calcium deposition occurring. And this is an X-ray from a publication with a patient with scleroderma, and you can see that it's this very diffuse, punctate, disorganized blobs of calcium that are different from the relatively structured calcium that's present in the bones. So we're not going to talk so much about calcification and calcinosis today, but calcification and calcinosis itself can be a precursor to heterotopic ossification, and we'll talk a little bit about that in a moment too. But heterotopic ossification is a little bit different because this is calcification that now recapitulates the normal bone formation process. And so this can be seen in atherosclerosis. So atherosclerosis will often start out as a very disordered calcium deposition, inflammation driven, within the macrophages and within the vessel walls. But with long-term, over a long period of time, these calcium nodules can actually start to take on bone-forming properties in the sense that you will see cells that are present. You will see active remodeling. You will see the formation of lamellar bones, so organized structures that are present. Same thing with like valve calcification. And then heterotopic ossification, such as in this patient which has a traumatic amputation, you can see that in the soft skeletal muscle. We'll also talk a little bit more about neurogenic heterotopic ossification. This has become much more common because spinal cord injuries and traumatic brain injuries, it used to be that survival was relatively poor. That has improved dramatically in terms of the types of medical care that can be provided. But interestingly, you start seeing all of this heterotopic ossification, and is often in a similar distribution to the neurologic injury. So the critical thing about heterotopic ossification, it's the abnormal activation of a normal bone formation pathway, but in the wrong location. And so there's always been a lot of interest in terms of identifying common mechanisms, such as immune pathways and cells. This is often considered de novo bone formation in the soft tissue. And obviously, our goal as clinicians is that can you block the formation after trauma and surgery? And we'll talk more about this in terms of like hip replacement and elbow fractures, but also potentially to harness these mechanisms for tissue growth and repair. So when we talk about heterotopic ossification, there are a couple diagnostic features that are actually really important to consider. First of all, this concept of having the formation of mature lamellar bone is really critical. This is what distinguishes calcification and calcinosis from heterotopic ossification. In many situations, especially if the heterotopic ossification has been long-standing and has undergone a lot of remodeling, you can actually see bone marrow that is present. And in some of these situations, the calcification and calcinosis lesion is the starting point, and then these will mature. It's kind of like what I was talking about in some of those mature lesions of atherosclerosis. And if you do histology or immunohistochemistry or even now RNA analysis, RNA sequencing analysis, what you will see is that there's an activation of the genetic bone forming pathways that are present. Heterotopic ossification tends to occur in nodules, sheets, and ribbons. It's typically not like the little punctate depositions, and it's typically not sort of this disorganized type of calcium that is present. And heterotopic ossification can bridge joints, so this results in the loss of mobility. Um, there are situations where this will be present as an isolated nodule in soft tissue. This is particularly true after trauma, especially sports-related traumas, where the heterotopic ossification is very much localized. And in general, patients typically will present first with pain, potentially loss of mobility, but these are sort of the two critical features that are present. We talk a little bit about like swelling and inflammation. That tends to be present in many patients, but it's not always a guarantee that that is actually a sign. So it's really the pain and the loss of mobility. And if in the setting of an inciting trigger, that's what you would want to start to think about for heterotopic ossification. So there's been a lot of interest, in terms of how do you diagnose this? Do you have the clinical suspicion? What are the strategies to do this? And radiologic imaging is really the gold standard. And as you can imagine, it basically covers all of the different types of radiologic imaging that we use in um, the clinic for musculoskeletal diseases. X-rays are by far the cheapest and probably the most common way to diagnose the heterotopic ossification. It obviously has X-ray exposure, but it's very difficult to quantitate. And especially when you're trying to figure out like three-dimensionally what this heterotopic ossification might be doing or whether there's an intervention, it's not going to be sufficient. Most people will actually go to CT scan. It's generally relatively accessible and relatively quick, gives you 3D reconstruction so that you can get a sense of how bad and the specific locations of it. And when you combine this CT with either like a bone scan or an MRI, this can be very helpful, especially as you start to think about different aspects and complications from the heterotopic ossification, such as the potential for nerve entrapment or nerve compression, or vascular entrapment, that might lead to something like a compartment syndrome. More recently, there's been discussion about the use of diagnostic ultrasound. This is still a relatively new, for musculoskeletal ultrasound, this is still a relatively new technique compared to these other more traditional methods. It does have a bit of a risk because it is more subjective in terms of specific measures. And as you can imagine, the ultrasound penetration of bone can be poor, and so it actually can be very difficult to get very detailed images based on ultrasound. But the advantage of this is that it's portable, it's quick, and you can do it in the field, and so it is utilized particularly in under-resourced areas, where you're trying to get information relatively quickly. Interestingly, when we talk about heterotopic ossification, there aren't a ton of major laboratory changes. You can see some changes like a transient decrease in serum calcium. This is particularly related to traumatic heterotopic ossification. Increased CPK and CRP related to the increase in inflammation and probably muscle damage, increased PGE2 in the urine. Alkaline phosphatase level can go up, but it's often relatively mild. But these are sort of, when people look retrospectively, you can see these changes because during the actual event, especially in the traumatic event, if a patient has had significant trauma, which is usually one of the risk factors for the heterotopic ossification, a lot of these things are going to be changing anyway, and it's very difficult to tell, whether this is HO related versus the trauma related. And just to give you a sense, Ben Levy's group had actually collected a bunch of data about some of their traumatic HO patients and had shown that the alkaline phosphatase can be elevated, but it's typically not a very high elevation. And again, the inflammatory markers are usually up. So this is unfortunately a relatively non-specific set of markers. I will point out that people have actually been very interested in looking at bone turnover markers, like CTX and peptide, and those have not shown any clear correlation with heterotopic ossification risk or with heterotopic ossification formation itself, making it not particularly useful, if you're trying to decide if that's what's going on. Okay. I would just like to remind people, if you have questions, go ahead and put them into chat. I can't see the chat at the same time, but I will try to monitor that on a regular basis to answer questions. So one of the things that one of the approaches that we like to do is to think about the different types of conditions associated with heterotopic ossification. And in general, we break it down into three sets or three classifications. One is traumatic, that's in the setting of a fracture or surgery, arthroplasty, muscle trauma, burns, high energy trauma. One is neurogenic, and I think this has, again, been growing over the past 10 years in terms of our understanding. This is typically going to be things like spinal cord injury, stroke, traumatic brain injury, and to some situations, central nervous system tumors. And then genetic causes. And there aren't a ton of genetic causes that are clearly identified. These are the three that are known in terms of major associations of a specific gene mutation or a gene that's involved with heterotopic ossification. And one that is growing and has been around in terms of potential risks for quite some time is an iatrogenic situation where patients who may have received some sort of bone cement that has been infused with BMP augmentation, those patients are at higher risk of heterotopic ossification from BMP leaching out of the constructs. So I'm just going to go through each of these in a little bit more detail briefly, and there's opportunities for discussion about some of this a little bit later on. So the classical description of non-genetic heterotopic ossification is really trauma related, and there is a male to female ratio that has been reported in the literature, roughly about 3 to 2, with history of trauma being present in about 75% of patients who have of non-genetic heterotopic ossification. Now, this male to female ratio, there's a lot of controversy behind it because it turns out that the ratio of trauma is higher in males relative to females at baseline. And so it's actually not clear whether this is a predisposition versus, a sex-based predisposition versus a sex-based risk based on risky activities that are more likely to give you high energy trauma. So this ratio is just something to keep in mind. If you look at the types of trauma that are involved, orthopedic surgery is actually, significantly associated with heterotopic ossification. And these are sort of upper limits that have been quoted in the literature. There is a huge amount of variability. So, for example, people will say 40% of hip arthroplasty is associated with heterotopic ossification. But this is highly dependent on the surgical site, like the clinical site or hospital and the clinician who's actually doing this procedure, the approach, whether it's anterior or posterior, and even things like the degree of injury, and what triggered the hip arthroplasty, whether it was a traumatic fracture versus, some other sort of procedure that's present. In addition, fractures or dislocations, specifically in the elbows and hips, seem to be associated with an increased risk of HO. And things like high energy trauma, traumatic amputations, those are definitely risk factors, as well as third degree burns, so severe burns that are present. We'll talk a little bit more about some of this incidence because what is actually useful to know is what is a clinical site's specific history of heterotopic ossification. Because, for example, we did a study over at UCSF, and which I'll show you in a little bit. The incidence was definitely not 40% for hip arthroplasty. So what is contributing to this variability is really unknown. And on the right-hand side, I'm just going to show you, the importance of trauma. This is a 52-year-old patient that I have in my clinic who the only thing that we can identify in terms of trauma is that she had repeated injections, intramuscular injections into her thigh, maybe about 10, 15 years ago, that she was doing using it was unfortunately a naturopathic therapy for her situation. But we think that that's actually what has triggered all of this heterotopic ossification that is actually forming here. One of the other factors that we consider is this importance of this concept of polytrauma, meaning that it's presence of more than one traumatic event at a time. And so you can think of this as patients who have a very severe motor vehicle accident where you might have a fracture plus a central nervous system injury plus other types of trauma and infection and things like that that are present. This is a complex and multifactorial process. We don't exactly know what all of the contributors are to this, but again, hypoxia, hypotension, organ and soft tissue injuries and fractures, these seem to be all correlated with worse outcomes in polytrauma. Likewise, ischemia and reperfusion injuries, the presence of a compartment syndrome, presence of infections, and more recently, I think people have really started to think carefully about the issue of repeated surgical interventions. And so we have seen patients who have had a spinal fusion surgery and then have had multiple revisions to that spinal fusion surgery, and that has really continued to trigger additional heterotopic ossification, and formation in that area. So the mechanism behind this is not totally clear, but this likely is a result of hyperactivation of the immune system, and there is some data that autoimmune medications can be very helpful for managing these types of risks. But it has something to do with probably the immune system and the activation of the tissue repair responses. So. And actually, this is a patient. This is the patient that I was mentioning a little bit earlier. He actually had an original spinal fusion that was done a number of years ago, which he was not happy with, and has actually gone through a number of elective surgical modifications. And you can see that along his spine, the entire thing is heterotopic ossification. There's heterotopic ossification on the anterior side. His sacrum is completely ossified. He's totally miserable, and he still wants more surgery because he thinks that the surgery is actually going to help him to improve that. And unfortunately, in his situation, that's probably not going to be the case. Okay, so this is the study that just to show you a little bit, we were interested in trying to understand what the risk factors are for heterotopic ossification and hip arthroplasty. And as you can see, our ratio here, of heterotopic ossification is not 40%. It's actually significantly lower at our site. But a couple of things that really sort of stood out to us were things like pre-existing spine disease, pre-existing osteoporosis, postmenopausal status, things like diabetes, which we know are very much inflammatory and result in inflammatory conditions. Those are also significant risk factors. And one that we point out, which is definitely modifiable, is vitamin D deficiency, right? So there are a lot of factors that sort of come into this that really put patients at a potentially higher risk for the heterotopic ossification. The question is that, with so many of these, how do you actually figure out which ones are relevant? Was that Laura?
Yeah,
Sorry.
quick question.
Yeah.
What do you mean by spine disease? In other words,
Yeah.
ankylosing spondylitis, or could you just define?
Yeah.
Thanks.
So we basically put in that spine disease was actually based on ICD-9 codes, but basically it covered any sort of condition that involved the spine. So that would involve things like ankylosing spondylitis, scoliosis, fractures, spinal compression fractures, kyphosis, those types of things. So anything that actually involved the bony part of the spine.
Thank you.
Okay. But did not include, but it did, I should clarify, it did not include spinal surgeries, right? So we basically wanted to exclude that out of this. So, okay, so traumatic HO is probably the most common. The second most common aspect to think about is probably neurogenic heterotopic ossification. And this is really associated, it was first described as being associated with spinal cord injury. So not to the spinal column, like to the bone and the vertebrae, but actually to the spinal cord, as well as to central nervous system injuries. There's data it's clearly associated and worsened by polytrauma. It is thought to have somewhere between a 15 to 40% incidence in patients who have had spinal cord injuries or CNS injuries. But again, this seems to be very variable. And so there's more work that needs to be done to really focus down on specific risk factors. And again, males seem to be greater than females. The exact number is under debate. Again, this may be correlated with epidemiologic risks of trauma, and so it's not totally clear whether that is actually a clinically relevant difference that's present. Interestingly, again, hips, shoulders, elbows, and knees seem to be the most common sites for this. It is not clear why these sites are predisposed to the different types of heterotopic ossification, but that seems to be a theme, is that you'll see the HO seems to be anatomically, that there may be anatomic reasons for favoring one tissue or another. In patients who have been studied with neurogenic heterotopic ossification, risk factors include longer coma duration, longer mechanical ventilation, and immobilization. And there is new data, especially using some animal models, that really suggest that diffuse axonal injuries are probably a key risk factor for that. One of the factors that has been classified as neurogenic heterotopic ossification, but kind of crosses over into different, between neurogenic and traumatic heterotopic ossification are blast injuries. And Jonathan Forsberg has done a number of really amazing and interesting studies, where he's taken like different types of cells and actually wrapped them in Kevlar and then blown them up. And then you can see that type of shock is actually capable of triggering those cells to enter an osteoblastic pathway. So there's something about that physical aspect of the blast injury that is really important. But in a study based on outcomes in Afghanistan, 70% of patients with a blast injury plus some sort of either or orthopedic procedure, or 86% of patients who had an orthopedic procedure plus a traumatic brain injury, these patients actually developed heterotopic ossification. And there have been some, the unfortunate, like the London bombing, as well as like, the Boston Marathon bombing. People have been interested in studying these patients, to see what exactly the risk is. And it does seem that there is this increased risk between explosive blast injuries and traumatic brain injuries and heterotopic ossification. And this is actually an image of a patient from the London bombing a number of years ago that generated a significant amount of heterotopic ossification at their site.
Ed?
Yeah.
And this is Emily. Hi.
Hi, Emily.
Real quick question. Have you noticed from reviewing everything that there is the male predominance pre-pubertally?
Yeah, so it's a good question. So one of the interesting risk factors, I think, is age. And heterotopic ossification, although it does occur in kids, doesn't seem to be as common as in the older population. So it's not totally clear. I don't think that there is enough data to be able to say whether the male versus female, the sex difference is actually different between younger patients, prepubertal patients, and postpubertal patients.
Okay, thanks.
Yeah, that's a great question. So, I mean, it's something that could be studied in animals, but and there are, in the genetic conditions, which we'll talk about, there really hasn't been a clear sex difference that has been identified, at least in patients. There's some data that there is potentially a sex difference in mice, but how that translates into the human clinical condition is not so clear. So, all right, so I'm just going to touch upon the three common genetic factors, genetic conditions of heterotopic ossification. The first one is FOP. So just to for these genetic conditions, these tend to present early in life, and so they have surprisingly a number of shared characteristics. Typically, a sensitivity to trauma, heterotopic ossification that occurs early on and might actually start early in childhood. And in some situations may be associated with changes in developmental milestones. So we've had a number of the young kids who present basically because, oh, well, they had difficulty walking or that they seemed really stiff. And so these, types of things kind of trigger the workup and the evaluation for thinking about, the genetic causes of heterotopic ossification. And many of these can be associated with unusual pain and swelling. So the most common one that's been talked about and which our lab also studies is FOP. This is fibrodysplasia ossificans progressiva. This is a patient who, when he passed away, donated his skeleton, and you can see that there's this huge amount of heterotopic ossification that is superimposed over the native skeleton. It's relatively rare. It's about 1 in 1.4 million. But there is a suspicion that actually that is an overestimate of the rarity, is that is actually more common than we think. And unfortunately, there are still some treatment options, but no really completely effective treatments that are available. And the ossification occurs in the tendons, the cartilage, and they're associated with injury. So, just to give you a sense of what this is a patient who had that I had seen that had a barrel chest, really neck was completely fixed, no flexion or extension, multiple bony lesions. And one of the things that we like to point out is the great toes. This patient, as you can see, is actually missing all of those wrinkles in the proximal joint, and that's because there's a malformation in the great toes. And so this for FOP. This is sort of the classical aspect, is looking for changes in the great toes and to some degree some shortening of the thumbs. And this is often one of the earliest presentations that can be identified even before, this is the development aspect, even before the flares and the heterotopic ossification that occurs. And we've talked about FOP in this teleecho before, so I'm not going to go into a lot of the detail, but this is useful to see. This is a patient with a flare that's ongoing. This is probably one of, this would be on the more dramatic spectrum and more obvious, in terms of this golf ball size, red, indurated, swollen lesion. That will eventually go on to form bone. Not all patients have these massive inflammatory responses, but when you see this, particularly in a child, it is and combined with the toes, this is very important to sort of think about FOP as a potential trigger. And one of the things for us about FOP that's been very helpful is that it's been a great system for us to think about and examine what are the different factors and the cell types and things that go into development of heterotopic ossification. And so, just very quickly, there's this hyperimmune process that seems to be present, very strong pro-inflammatory situation where there's lots of different types of cytokines being produced. There's activation of the pro-inflammatory pathways, activation of pro-inflammatory cells, and that this inflammatory cell milieu really causes additional recruitment. And more recently, what's been shown is that the FOP mutation in ACVR1 causes the receptor to misinterpret activin A as a BMP ligand, and it activates tissue-specific osteoprogenitors, specifically fibroadipocyte cells that then turn into the bone. And so this has allowed us to think a lot about potential points for intervention, as well as to realize that if you compare what happens in patients with FOP in terms of their inflammatory responses and potentially the cell types, many of these appear to be very similar to other types of heterotopic ossification. So like in traumatic heterotopic ossification or in burns, you see pretty much the same spectrum of cytokines that are coming up. So the mechanisms are probably a shared common mechanism in terms of triggering more bone formation. In terms of thinking about different types of therapies, at least for FOP, there's been a lot of interest in this drug called palovarotene, which blocks bone morphogenetic protein signaling. So, it has potentially a direct benefit of targeting the ACVR1 gene, but it also blocks cartilage and bone formation. And so the idea behind this was to test whether palovarotene could block heterotopic ossification in patients with FOP. And I'm just going to share the conclusions from the phase 3 open label study because palovarotene has now been approved as of last August, so almost a year now. But basically, they recruited patients with the classical version of FOP. They used whole body CT scans to quantify the heterotopic ossification, and they compared it to an open label natural history study cohort. And in post hoc analysis, what you were able to see is that the patients who received palovarotene actually had somewhere between a 50 and 60% reduction in the amount of new heterotopic ossification. Interestingly, if you go and take a look at some of these patients in long-term analyses, you can see that the patients who were treated over a longer period of time had less heterotopic ossification than the untreated. And because palovarotene had a couple of issues in terms of safety, toxicity, to the bone, growth plates, and also just interruptions because of some of the data analysis issues. This allowed the teams to actually analyze sort of an on-off-on treatment strategy. So for patients that were on palovarotene, you can see the annualized new heterotopic ossification was about 9,000 cubic millimeters per year. When they came off of it because of the FDA holds that occurred, heterotopic ossification appeared to go up in the off treatment phase, and then the patients who were restarted on palovarotene, their heterotopic ossification appeared to come back down. So this, together with some of the data, really does suggest that palovarotene may have benefit for FOP-related heterotopic ossification to reduce the new heterotopic ossification. So the second genetic disorder that I just want to touch upon briefly is POH, or progressive osseous heteroplasia. This is an interesting condition that is associated with Albright's hereditary osteodystrophy, which is an inactivation of the GS-alpha protein for G protein-coupled receptors. Many of these patients so the patients typically have a loss of GNAS function, and many may have mineral metabolism changes. And interestingly, this heterotopic ossification starts more in the subcutaneous region and eventually extends into muscle and can be extremely destructive. For whatever reason, it seems to be a little bit more plate-like in terms of the structure. For people who are interested in G protein-coupled receptor signaling, the GNAS loss of function diseases, there are a number of them, and they have very challenging names because they're going to be like pseudo-hypoparathyroidism and pseudo-hypoparathyroidism. But this is a summary table of some of those features. But what you can see is that there are a number of patients with the pseudo-hypoparathyroidism that can get superficial calcinosis that could eventually become heterotopic ossification, but typically is sort of the superficial calcinosis. And I'll show you a picture about this in a moment. But what we're talking about for POH is really a different situation where these are deep, very significant bone formation, heterotopic ossification that is occurring. And the two of them actually have different characteristics on X-ray. So here's an example of one of my patients who's a 55-year-old, and she has Albright's hereditary osteodystrophy. And this is her foot X-ray. So she complains of a lot of foot pain. And what you can see is all of this basic snow that is actually present of all of these little calcifications that are present. This is cutaneous calcinosis that is present. And this is from the literature. This is a patient with POH. And what you can see is there's this extra sheet of bone that is sitting here on top of the foot. And this is a child. This is a 5-year-old child that you can see that has this invasive bone that is actually present. And it looks different, right? That this looks like a very punctate, sort of disorganized type of calcium. This looks like much more organized and actually, following soft tissue planes.
So Ed, another thing, sorry I keep bugging you.
No, this is all good.
So in PHP1A and PPHP, I've found in many, many patients that these, what you find is actually bone. You know,
Hmm.
some even forms bone marrow components. And so it is bone, but like you said, it doesn't go beyond the it's all in the
It's
subcutaneous layer.
cutaneous, yeah. Yeah.
But this is where my question came before. It's clear that there's a male to female predominance, um, throughout in,
Hmm.
kids and adults in this PHP 1A and PPHP. So
Yeah.
that's why, that's where it stemmed from.
Mm. Yeah, the male to female predominance in PHP and PPHP, I've I don't have a good answer for that, and I would defer to you because
Yeah, I'm
that's
looking at
your
that
expertise.
now.
But
So I'm looking at hormonal causes,
yeah,
um,
but
because it does seem worse as they get older. But that's why I was wondering, just in general, in ossification formation,
yeah,
I'm so specific to looking at PHP1A and PPHP that, I don't see the forest for the trees. And that's why I wanted to get your input just in general, what you've noticed in kids through, versus adults. Again, they always are worse in adults with
yeah.
time. But that's where the question came from, because you do worry about hormonal versus just extra trauma in boys versus girls, like you said.
Yeah, and I think, especially for the PHP and the PPHP, we've also wondered whether, what the impact of imprinting is, right? Because we've wondered not only, I think the sex differences and potential sex hormone differences, I think are definitely factors that need to be considered. But we've also wondered, is there differences in types of imprinting? Because we've had, and we can talk about this separately, we've had one or two patients with kind of unexpected family histories that don't really quite match up with the classical description of, paternal versus maternal
Yeah.
heritage,
So
and whether or not that might be a
in
factor.
1A versus PPHP, it seems identical,
Yeah,
so that it's not imprinting, but I can only speak to that.
yeah, yeah, yeah. So,
Hi, Ed. This is Harold.
hey,
I,
Harold.
I have a related question. I mean, in POH, you often have only certain regions of the body that are affected, right?
Yeah.
So could it be that there's actually a second mutation that occurs somatically? And is it conceivable that this second mutation is actually also affecting GNAS, the exons encoding GS alpha?
Yeah, that's a great question. I think the possibility of a secondary mutation is always intriguing. I've actually wondered whether there's a second hit of different sorts, like that there's been trauma or additional factors in that particular anatomic region, right? Because I wouldn't have expected, because the GNAS inactivating mutations can be inherited and should be actually present within all of the tissues. Why is it that only specific regions, right, are affected? And I don't know if there's a clear answer to that. Maybe Emily has some thoughts on that.
I don't know if there's, Harold, I wondered the exact same thing. It's so intriguing, and I don't think there's a true answer, although if we saw, is Fred Kaplan on?
Yeah,
Um,
I saw Fred a little bit earlier. I don't know if
yeah, or Eileen, because it's very intriguing. And then it's also, typically in POH, it's mutation in the paternal allele and
Mhm.
the
Yeah,
impact of
in
that.
our New England Journal paper where we described the gene mutation in POH, we had a family, I think it was family 5 or E, um, from New Zealand, a father, and they had 5 daughters, and all 5 of the daughters had osteomycutis. They had a little trivial bone in the skin, nothing much. involved. But one of the sisters had a severe POH in one limb. And many of the sisters were married and had children, and they passed on the normal allele. They did not have, the children did not have any problems, obviously. But if they passed on the abnormal allele, they had endocrinopathies, not heterotopic ossification. But it's very interesting that one of the children had the POH, and the other four sisters had osteogenesis. It's interesting that the father had the genetic mutation, but I examined him and he was absolutely fine. He had no problems at all.
Mm-hmm.
And so from that family, and of course, all five of the sisters had the genetic same exact genetic mutation. So what we thought was that perhaps the daughter, the sister that had the POH, had a second mutation in a stem cell that followed in a sclerotome or dermatome pattern. And we noticed that many of the patients had the ossification in a sclerotome or dermatome pattern, like Ed in this picture on the right with the red arrow. It sort of follows the L5 dermatome.
Yeah.
But so we did a study in JCI in collaboration with folks from Tufts University, and we did hypomorphic alleles of GNAS, and we found that when there was about 50% reduction, we got the osteomycutis, but when we had more than 50%, the chickens, this is a study done in chickens, the chickens were born with POH-like lesions. And we injected these hypomorphic alleles into early embryos, into specific dermatomal or sclerodermal locations. So, we haven't proven it, but it suggests that there is a secondary mutation either in that gene or in the pathway in some of the cells in that particular location.
And I think that there's a lot more understanding now about like the pathways downstream of GNAS, right? Sort of the Wnt and the hedgehog.
Right.
And I think that to speak to Harold's point, it is possible that there are modifications within those that would potentially predispose, right, to heterotopic ossification.
Yeah.
I hadn't thought about I'd forgotten about the dermatomal aspect of POH, which was an interesting observation, right? Because that also sort of raises the other possibility of sort of a neurologic sort of interaction, right? So
absolutely,
that's something else. And then just to speak to what Emily was saying, one of the other intriguing aspects, at least for a number of our patients with the osteomycutis in cutis calcinosis in the AHO patients, it seems to be very much trauma related, right? So the feet tend to be much worse affected than other sites, and so there is potential for other the involvement of trauma and inflammation in some of these patients. And I will say that for this 55-year-old, we just, for a number of reasons, we actually tried her on steroids and actually also on anti-IL-1 therapy. And she had very dramatic improvement at the beginning. She felt much, much better. The pain was significantly decreased and the swelling significantly decreased in her feet. But she couldn't tolerate the medication for a prolonged period of time, so we had to discontinue it. So there's probably also an inflammatory and trauma component that contributes. All right, so there's this recent paper, which I think, I thought FOP was bad, and then I saw this paper was brought to our attention, and this is, I don't think there's actually a name for this disease yet, but this is the gene mutation, and it's a mutation in a Rho-GTPase family member. And it turns out this is an enhancer mutation that leads to an abnormal misexpression of this particular gene. And this is a 5-year-old boy. And as you can tell, it is a huge amount of heterotopic ossification. So, there are a number of pathways that we just don't understand in terms of what regulates this process of bone formation. Yeah. Okay. So treatment. This becomes, I think, to me, a little bit simpler now because there isn't much. Many of the mechanisms for the heterotopic ossification really seem to converge on inflammation and sort of in an abnormal inflammatory response. And so I think what you'll see is that, in terms of the different types of therapies and the therapeutic approaches, people have really sort of targeted these aspects. And there's actually suggestion that there's really significant shared mechanisms, particularly on the inflammatory pathways. Ben Levy's lab and a couple of other labs have really focused on like burn injuries and trauma. And many of those cytokines are very similar to the cytokine changes that we see in FOP. And so perhaps that is sort of the final common pathway, towards triggering the bone formation process. But if we take FOP as an example and just thinking about like potential therapeutic strategies, you can go for things that are very directed. So these are obviously going to be towards the genetic diseases, genetic repair, kinase and other types of inhibitors. But you can also move further down into more mechanistic type things. And these are going to be like blocking of the ossification and blocking inflammation. And so, there are a number of different medications that have been tried in different for that target all of these different stages. And we'll talk very briefly about some of those. But I think this is a sort of useful structure to look at the types of therapies, because certainly the ones that are currently standard of care, for even though they are not particularly efficacious for heterotopic ossification, are going to be more of these mechanistic targets, that sort of target the common pathways. So as I mentioned, unfortunately, there really isn't much, in terms of options. The key thing I would say is really avoiding trauma. And avoiding additional surgery, especially because there's a high likelihood of recurrence that occurs. It triggers more inflammation. This whole process appears to be a cycle. Anti-inflammatory medications have traditionally been used in heterotopic ossification, and particularly non-steroidals. Indomethacin is widely used, but as many of you may have seen in a number of the reviews, the papers are down here, it's really unclear benefit. Some studies say that there's benefit, other studies say that they're not. A number of different NSAIDs have been examined. I think that, at least here we have been using NSAIDs basically because it might help, and if it helps, that's great, but we don't really have clear data that says that it will help. Steroids have been the mainstay of reduction of inflammation. This is particularly true in FOP. Steroids are also used in neurogenic and heterotopic ossification and also CNS injury, partly because of the management of the CNS injury, but also partly because of the potential benefit for decreasing overall inflammation. And radiation therapy is something that has been proposed for a number of situations, particularly recurrent heterotopic ossification, or if there's something that can be relatively defined in terms of a start point. So such as, if you have to consider for urgent surgical resection, or some sort of surgical procedure that might be occurring. There has been a number of case reports where people have said that actually neurogenic heterotopic ossification might actually be worsened by radiation therapy. This is not so clear either. But interestingly, one of the things that has been demonstrated to be helpful is encouraging mobility, and so doing range of motion exercises. This does not typically stop the heterotopic ossification, but it does result in increased quality of life. And there are a number of investigational therapies for heterotopic ossification. I list etigenate as an investigational therapy, mostly because you can't really get it anymore. This is one of the older non-nitrogenous bisphosphonates. It was actually approved by the FDA for the use of heterotopic ossification after spinal cord injury or for hip replacement, but it was discontinued for unknown reasons. It was discontinued first in the United States, but now I've been told it's actually not available in Europe either. And it's not known if the amino bisphosphonates are of any benefit. People have switched to those, but it doesn't seem to have, as much data behind it. Palovarotene, as we had talked about, there's data now that shows that it reduces new heterotopic ossification in FOP. There's animal data that suggests that there is potential benefit for non-genetic heterotopic ossification. So I think there's excitement in thinking about palovarotene as a medication for that route. And then anti-IL-1 and JAK inhibitors. There is human data suggesting that there are benefits for patients with FOP, again, genetic heterotopic ossification, and some animal data that suggests that these pathways are really critical for neurogenic heterotopic ossification. So these might be directions, again, unproven, but potential therapies for blocking these types of heterotopic ossification. So as you can tell, there's a lot to do. We have actually quite poor definitions of the risk factors for non-genetic heterotopic ossification. We know that it's a risk, like trauma, but we haven't been able to really quantify it. Even the diseases with genetic heterotopic ossification remain challenging, as you've heard. Is there a sex bias? Is there a particular sort of genetic multi-hit contributors? What are the interactions with the environment and with the inflammatory pathways? And so I think as we develop better animal models, the hope is to really identify additional cells that are driving heterotopic ossification. And FOP, the fibroadipocyte cell, seems to be a major factor for that. But is that true for other types of non-genetic heterotopic ossification? We don't actually know. And likewise, the identification of molecular targets for potential therapies. There's been a lot of interest in this. We would really like to move away from very broad sort of approaches like steroids and anti-inflammatories or radiation therapy to more specific targets, for blocking the new heterotopic ossification. So lots of things to do at this point. So in conclusion, heterotopic ossification remains a significant medical challenge. It's highly variable, very broad risk factors. Medical management is lacking. Surgical management, it's really limited because you run the risk of actually triggering more heterotopic ossification. Lots of opportunities for research, and it sounds like there's a lot of people here on this Zoom call that have interests. And so, I think thinking about these types of opportunities, thinking about how we can leverage human samples to understand and answer some of these questions is really going to be exciting. And so with that, I'm going to stop and thank my team. We've been very fortunate to have a very nice translational group where we do everything from the molecular biology and cell biology to human samples and to human clinical research, as well as a number of collaborators that have really helped make all of this possible, as well as our funding sources. And I'm grateful that a number of those collaborators are actually on this call today. So thank you. Please tell me if I'm wrong on anything. I always like to learn. So. With that, I will stop because I hear that there may be some cases to discuss.
I can't thank you enough. That was just wonderful. Thank you. Great. Yes, I'm going to push on because particularly Steve Ng has a great case that I think we have the perfect audience for. Just Melissa, quickly our slides. To remind, we are beginning year 6, and this is just amazing, and thank you all for being with us. Please join us next month for Smita Jha talking to us about decoding primary hyperparathyroidism, genetic insights and advances. And remember, there's now an OI teleecho series. I'll be talking about the challenges of transition in 2 weeks. Please note this is a Wednesday. And then in October, Eric Orwell will be talking about medical management of bone fragility in adults with OI. I'm going to just rush right along because I know Ed has a bit of a time limit. So I want to be sure that we discuss Steve's case. And so, Dr. Ng, thank you so much for being with us today. And won't you share your screen?
Is it up?
Yep, we're
Okay.
great. Thank you.
Hi, everybody. I'm a clinical endocrinologist seeing adult patients and based in Columbus, Ohio. Have a case of HO to present and very eager to get everyone's input on this as I really don't know what's going on and need some help. This is a 38-year-old African American, previously healthy male. He's got a very limited prior past medical history. He was a baseball player in college and had a right knee injury and surgery at that time. In 2018, to treat degenerative disc disease leading to radiculopathy, he had lateral interbody fusion, a limited one, L2, L3. I do not know whether BMP was implemented during that procedure. This was at another institution. So he's overall well until the summer of 2022 when he presents with swelling and pain in the left knee. Uh, it is really limiting his ability to walk and just perform routine activities. Notably, the pain and swelling was not preceded by any traumatic event. X-rays show ossified bone forming mass along the posterior aspect of the tibia. Does not appear to be cortical medullary continuity or aggressive features or cortical destruction. There's some degenerative changes. So here is at the X-ray on the left panel. You can see the HO. Here are just AP views, but it's fairly large, about 5 centimeters, which we'll see in another image. He proceeds to an MRI. Here's the size of this lesion. Again, not contiguous with the medullary space. I think the orthopedic oncologists were thinking about osteosarcoma potentially. On the MR, there is some enhancement along the superior aspect of the lesion, and there's edema and enhancement on surrounding soft tissue, but no definitive soft tissue mass is identified. So he sees one of my colleagues in orthopedic oncology. They review the prior imaging and the story. And their differential diagnosis is heterotopic ossification arising from the popliteus muscle or a synovial chondromatosis or parosteal osteosarcoma. They obtain a CT of that left knee. So a lot of this is reiterating what was already seen before, cortical-based lesion on the posterior margin of that proximal tibia. And it does have, according to this radiologist, a possibility of osteosarcoma. So tissue sampling is recommended. Okay, so here's that CT, sagittal views and axial views. It's on that posterior aspect of the proximal tibia and significant in size. A bone scan is also obtained. And you can see here's that left knee showing that increased uptake. There's also areas of increased uptake on the other side, the right knee, and the distal right tibia, that medial ankle area. There's uptake in the shoulders bilaterally, in the acetabulum, and along this L5 vertebrae here. So An MR of the pelvis is obtained, and to further look into that acetabular lesion, and it's measuring 3 to 4 centimeters along the anterior inferior iliac spine. Um, that seemed to be an area that could be amenable for tissue biopsy. So interventional radiology sticks a needle. The biopsy report shows what seems to be benign appearing tissue. Um, the but they also wanted further tissue for evaluation. So the patient goes on to excision of this mass at the back of the left knee. It's almost 6 centimeters in size here. The pathology shows heterotopic ossification. Here's some immunohistochemistry. Um, so radiographs of other areas include the right tib fib. There's a exophytic lesion along that right medial malleolus. A radiograph on the left shoulder, similarly on the medial calcar of the proximal humerus. Interesting that right knee did not show any worrisome lesions. There was moderate degenerative changes, irregularity at the right patella. Moving on, maybe half a year later, he has increased swelling and pain in that right ankle area. CT is obtained. What was seen before is now measuring 3 centimeters. The patient undergoes excision. This was painful. HO is found again, and similar to the prior surgery. He that about half a year later, the left knee starts to hurt again, and there's an MR that is showing surface-based cortical bone formation without evidence of intramedullary extension or cortical destruction. So it seems like something on that left knee is recurring. Well, the orthopedist now sends the patient to internal medicine subspecialty providers. A rheumatology colleague saw this patient September last year. You can see normal calcium and other serum mineral concentrations. Interestingly, the 25 hydroxy vitamin D is in the single digit range, but there is no abnormality of PTH. Alkaline phosphatase is elevated with an increase in a number of ISA enzymes, not just bone. I see this patient last fall for the first time. In addition to what I previously showed, his medications are really based upon along the lines of pain control. His family history is negative for somebody with a bone condition or a calcium parathyroid condition. Mom had colon cancer. He was a security guard, but these lesions have led to inability to work. He has no kids. He's non-married, never married. He is not short. He's 6'5", 195 pounds. And during that first visit, he was really crying and despondent over what's been going on over the past year. He has an antalgic gait. There are scars along the 2 areas that have had surgeries. There's maybe some fullness along the back of the knee, but I'm not able to really appreciate these areas of ossification. Looking for any features of Albright's hereditary osteodystrophy, I wasn't able to appreciate any. Dr. Hsiao put this kind of classification up before. So notably, there's not been any trauma, no spinal cord injury, traumatic brain injury, no prior stroke, no soft tissue injuries. He's not had surgery on that left knee. That ligament problem from the baseball accident was on the right side, actually, the opposite side. He's not had a burn. A few other items that I saw on this art review paper by Dr. Kaplan some years ago, which include, interestingly, some arthropathies, but none of these turned up from the evaluation from the rheumatologist. And we've got FOP, POH, AHO. This tracheopathia osteoplastica was in here, but he doesn't have anything that's bone-like in the area of the trachea. So thinking about genetics and GNAS, I referred him to our clinical geneticists. They obtain an in vitae skeletal disorders panel that's got 358 genes. Specifically, I was interested in GNAS, but that was negative, and so was the gene for FOP, or whatever that's worth. There were some variants, this heterogeneous VUS for this gene, which I've never heard of before, nor the syndrome that it's associated with. But anyway, this is an autosomal recessive disorder of dwarfism, which obviously the patient does not have at 6 feet 5 inches of height. There's this benign heterozygous variant that leads to measurement of the enzymes that are involved with one of the mucopolysaccharidoses, Hurler syndrome, but it's actually a benign thing, just leads to a lab abnormality. Anyway, this patient is in a lot of pain. I'm wondering what to do, and didn't have another thought except to offer zoledronic acid. So he gets this in November of last year. Around this time, unfortunately, he has a fall, and that leads to a comminuted fracture in the left distal femur, and this is fixed surgically. As I see him over time, he'll tell me that he's not in any improvement, that pain is not improved, but his affect does seem a little bit improved. So maybe there is something going on with Zol and bone pain. I repeat a technetium whole body scan, so that here on the left panel is the initial one. Here on the right is the follow-up one in February of 2024. I'm not facile enough on the PAC system to get the intensity and contrast to match, but so these are not exactly the same apples to apples comparison. But the radiologist reading this says the uptake is less at the left ankle. Now he's had surgery there to remove that lesion. It's less at the left knee. This is before, this is after. It's also less at the right knee and at the left humerus. There's new increased uptake at the left distal femur. He probably didn't know that now there's plate and screws there after that distal femur fracture. There's increased uptake at the right acetabulum. And no change at the left acetabulum where that biopsy had previously been obtained, and at that L5 area. So a little bit of a mixed bag on the bone scan results. Here's a progression of that left knee. So this is what I've shown before prior to the surgery. This is after the surgery. And then here, maybe a year later. This is the distal femur in November, and then here in April of this year, the distal femur seems to be um, progressing in another HO lesion. I said I had given him Zoll. During that first visit, he was in so much pain and crying so much I wasn't able to get any labs. But so I don't have reclassed bone turnover markers, but here's a couple of sets that follow the first infusion. And I don't know, didn't have anything else to offer. So it seemed like maybe Zoll was working with the bone pain, so he got another dose in April of this year.
Steve, I'm going to ask you to, great, wrap it up
Yeah.
because I do want to have time for discussion and we're
Yeah.
getting short. So great.
Yeah. Is there an underlying condition to explain the HO? Is there a role for other tests? And specifically, we can sample the HO bone. We've got it sitting in the freezer, and thoughts on how to control his bone pain. With that, I'll stop sharing.